Okay, wonderful students. Now, when we go into your Hinkle MedSurg book, this is the book from Bruner and Sudarts. But when you do your readings in the Hinkle book, you will note that some of this information will be a repetition or a condensed version, or it may be in an extended version of what we have already covered in your Taylor Fundamentals book. And some students sometimes get upset about this, but what I want to say to you is this. The reason that we do repetition and repeat concepts and information time and time again is because that is proven how you get that in your long-term memory and you won't forget it, right? And as a nurse, you really need to remember all of this information. So that's why we do repeat certain information, especially the very important information that you need to know. So please know there is a method to the madness that we have done here. We are among the best in the country, which is a huge honor for us being a community college. We are above many of the universities across the nation. So there is a method to the madness, so please trust the process, okay? I'm going to put that soapbox away now. Okay, let's see here. So again, it's meant to be an additional supplement for you to help you moving forward to get that in your long-term memory. Florence Nightingale at the top part, and then the bottom here is the social policy statement from the American Nurses Association. So take a moment and read through it. This is genuinely what we strive to do day to day as nurses, right? And here's some definitions from the World Health Organization that you can take a look at. Now, here's a really important piece, right? Maslow's hierarchy of needs is a theory of motivation which states that 5 categories of human needs dictate humans' behavior, right? Based on the importance in their life. So those needs are the physiological needs, safety needs, love and belonging needs, esteem needs, and self-actualization needs. Maslow's hierarchy of needs is a model for understanding the motivations for human behavior. It really helps us as nurses, right, when we're prioritizing our patients' care and also, the severity of what's going on with them, right? It maps different motivations onto a pyramid, as you see in the picture, with each level representing a different human need. These include the physiological needs, right, like air, water, shelter, food, sleep, clothing, reproduction, those kinds of things, right? Then it moves on to safety, love and belonging, esteem, self-actualization, right? The significance of Maslow's hierarchy of needs in nursing care is to remind nurses that individuals' fundamental needs to be those fundamental needs have to be met before they can achieve any higher level needs, right? And so this application of Maslow's hierarchy will help propel us as healthcare professionals toward comprehensive care of the whole person, right? Not merely just looking at what disease or what chronic illness brought you in today that I can help, fix, but literally looking at all of their needs. Like, when they get done with this hospitalization, do they have access to, food and water and air and shelter? Do they have a place where they feel safe? Those kinds of things that are on your mind if you don't have those basic needs, right? They consume you if it's not met. So again, we're not merely trying to fix them up so they can survive, but rather to restore their health and function of mind, body, and spirit back to that pre-illness level, right? That's the goal. This is extremely important, and thus you must not only commit this information to memory, but really have a really deeper understanding of it. And we are going to talk about this continually throughout every single block and for the remainder of your career. I just want you to have the base understanding for right now for the health promotion activities. We are going to delve deeper into it, and you will be tested really deeply on these theories, but later on in the block. The one thing that we're supposed to be looking at with our country is having focus on health and wellness, right? With the Health and Wellness 2030 goals, right? I do hope you understand that we are a diverse community, despite what some people would like us to think about what the world should be looking like here. So we're going to talk more in depth about cultural diversity and cultural humility in week 4. But the one thing I'm going to bring up right now is you need to be aware that there are different folks with different type of priorities, right? And different cultures and different beliefs. And the best way you can find out about those things is to have true engaging conversations with these patients and ask them what's important to them, right? It's all about them. And we have to put aside any kind of um, biases, right? And entirely put our biases aside. And we have to acknowledge our biases and put them aside so that we can care for these individuals and respect them and their beliefs. They have a right to believe what they believe, just as I have a right to believe what I have to believe, and you have a right to believe what you have to believe, right? And we can do that in a mutually respectful way. And that's what's expected in a profession, right? In a career. Um, they may be the same things that are important to you, and they may not, right? But the only way to know is the important to interact with our patients and to have those discussions, what's important to them. Again, we talked about the Healthy People 2030 initiative, looking at what healthcare delivery and healthcare priorities we should be addressing by 2030. No, we're not going to give you a test question on these statistics, but it's something that you need to be aware of out there as you start getting ready to enter this crazy, beautiful profession that we call nursing and healthcare delivery. The other thing that we do that we have to look at here is we're going to talk about again. We're going to talk about this later on again, but looking at technology that comes into play when you're, working and being a nurse, and hopefully it works with us and makes our lives better and not works against us, right? I think we've all been in a situation where our IT issues delayed our progress and actually inhibited us from doing our jobs, right? So that's frustrating. But the goal of informatics really is to make changes that are beneficial and improve patient outcomes and patient care. So whatever system that you use for obtaining your data, make sure there's a way that that data gets housed by your medical records department and that they take care, quite well of that information, and make sure there's a way to mine that data to ensure you're getting the best possible outcomes by truly reviewing all of the information that's available at your fingertips. That will improve your patient outcomes and patient care, right? Because that's a guide to help you make the best decisions for the kind of care you're going to deliver for that shift and going forward. That's the mandate for everybody in healthcare, using electronic records right now to its fullest capacity, because it gives you the most current outcomes-based information. So of course we'll make better patient and safer patient decisions with the most up-to-date information, right? We're also going to be looking at evidence-based practice, and again, we're going to talk more about this later on into the block as well. But looking at evidence-based practice and what does the latest research findings show that we should be doing with our patient care delivery. And again, research findings just show something or support the use of something in place, right? It shows that, hey, this is what we did here and it worked really well. It doesn't necessarily prove anything 100%, but it rather shows the most clinically sound way to do a technique or process currently that will limit the amount of excess foreign invaders like bacteria, fungal, viruses and all of that, right? To enter the body and thus cause, further damage to our patients. And that's simply because as technology changes and as new treatments and medications come forward and change, the things that we used to do may no longer be practiced, right? Because it's no longer the best evidence-based practice. It's no longer the best, safest thing to do. So that's updated constantly. And that's again why we tell you, you should belong to some organization and also at least one literature to keep up on what's the latest findings in medicine, right? Because it's changing constantly. So why does Marcel, Wes, Belinda mention this continually throughout class, lab, and clinicals? Because you, me, we all have to be flexible and be educated on what's the latest, best evidence out there to support practices, okay? So one of the things you're going to have to do is you're going to have to read the professional journals out there again for nursing and healthcare delivery, and you're going to join those special organizations. I would highly recommend that you join, ANA or whatever large organization, and then specifically for whatever your specialty is. So like for me, hospice, I belong to a hospice, the hospice, like I said, HPNA, right? The Hospice Palliative Association. So You'll get access to those journals and the articles that they publish, and you've got to read, and be aware of what's happening in your area and practice, right? You also have to be very open to interprofessional collaboration because we're going to work with all kinds of people and that are going to be part of the patient care experiences. Nurses are the only ones, we're not the only ones at the bedside, right? We are the only ones that are truly at the bedside 24 hours a day, 7 days a week, along with the CNAs, right? But we're not the only ones, and we're not the most important, right? We're all equally have a piece of that pie. So having good interpersonal skills and good communication skills is key to your success, and therefore we're going to discuss this very, very thoroughly. We're going to test you. A lot of your test questions will come from uh, positive, proper communication skills, and you will be surprised that it's not as easy as one would think, right? But we're going to teach you all about those communication skills, the proper ones. Okay, so on this page, it just talks more about how you're going to have to be working together again with intercollaborating with the professionals. This is the collaborative practice domain, talks about working within the collaborative environment. All right, QSIN. So quality and safety education for nurses, or QSIN initiatives, are something you definitely need to know. Was developed to integrate quality and safety competencies into nursing education. So the 6 QSIN competencies include patient-centered care or person-centered care, teamwork and collaboration, safety, evidence-based practice, quality improvement, and informatics. The QSIN competencies can be and should be a framework for your nursing practice, right? The goal of the QSIN initiatives is to prepare future nurses with the knowledge, skills, and attitude. So many times you'll hear Wes, Marcel, and I say, and Denise say KSAs, or knowledge, skills, and attitudes, right? So this is what QSIN is for. It's to prepare you, the future nurses, with the knowledge, skills, and attitudes needed to improve the quality and safety of our healthcare system, right? Historically, nursing education focused on knowledge and skill acquisition, right? So this is what the disease looks like, and this is the meds you're going to give, and this is how you do it. But really didn't address the attitudes and the value of the nurse. So this is now a critical component of all nursing accreditation programs throughout the country, and it's important that you understand this information. Whoops. Sorry about that. Oh my goodness. I am just bouncing all over the place here. Sorry, you guys probably just had a seizure bouncing back and forth from those slides. I apologize for that. Okay, back on track. Nursing practice in today's society mandates the use of high-level critical thinking skills within the nursing process. Critical thinking enhances your clinical decision, right? Helping to identify patients' needs earlier and to determine the best nursing actions that will assist the patient in meeting those different needs that they have, right? In critical thinking, the nurses still distinguish claims based on facts, right? So we're basing claims, conclusions, judgments, and opinions. We're going to gather all the facts that either support that or lead to some other determination, right? And then we come up with a new goal. So the assessment of the reliability of information is important stage of critical thinking, where the nurse needs to confirm the accuracy of this information by checking other evidence and informations, right? So critical thinking skills have been linked to improve patient outcomes, better quality patient care, and improved patient outcomes, right? So it is a fact. When you critically think, you're going to have better patient outcomes, right? So, while problem solving tends to focus on the identification and resolution of a problem, critical thinking involves asking skilled questions and critiquing solutions. And to effectively critically think through the situation, a nurse must do, selecting the best scientific evidence relevant to particular patients, a complex process that involves intuition to apply to the evidence that's being provided, right? So it's really an intricate process, and our process here at MCC to teach you how to critically think works. And I will tell you as a student, don't be surprised if you get a little frustrated, but I want to tell you, try not to. Try to trust the process and know that in the end, you are going to be the best, most exceptional nurses. And it is a fact that employers across the state look for MCC graduates genuinely because they get a great education. So please trust the process. Um, let's see. We definitely are one of the top schools in the nursing education because our school curriculum teaches students how to analyze every different type of situation. Not only that, but to develop solutions based on high order of critical thinking skills, right? Some schools around the country will teach you just how to do skills like placing a Foley, an IV, how to access a port, one of those, but not how to critically think. And if you're going to be a quality nurse, you can't do it without critically thinking. For nurse educators who are responsible for undergraduate and graduate learners, teaching critical thinking skills is crucial to the future of healthcare. All right, I'm going to put that soapbox away, but honestly, jump with both feet into the critical thinking process, okay, as we start it in week 2. Let's see. I think when nurses use critical thinking and critical reasoning skills, they set forth on a purposeful course of intervention to best meet patient care needs. Rather than focus on one's own priorities, nurses utilize critical thinking and reasoning skills to recognize their actions must be responsive to their patients. So again, we're not going to like come up with a list of stuff. Okay, well, I got to change this IV and I got to do this and right. What we're going to do is we're really going to gauge our day based on where our patients are currently in their time. So yes, we're going to get report, but the first thing you're going to do after getting report is you're going to poke your head into your patient's room and place your eyes on them and have a conversation with them to check their neurostatus, right? Make sure they're alive and breathing, and then also start to gauge where on airway, breathing, circulation, and Maslow's, which we're going to discuss in week 2, how you prioritize those patient needs, right? It's not based on what tasks you have to perform, but rather how stable is your patient currently doing, right? And that changes from patient to patient from time to time. It's a continual assessment that you're doing all the time, right? So again, we're going to cover these thoroughly beginning next week, all throughout block 1 through block 2, 3, and 4, and you're going to utilize this information with each and every patient moving forward. So you can see how critically important it is, right, to do it. Successful nurses think beyond their assigned tasks to deliver excellent care for their patients. For example, a nurse might be tasked with changing a wound dressing, delivering medications, monitoring vitals during a shift, those types of things. However, it requires critical thinking skills to understand how a difference in a wound may affect blood pressure, temperature when you're changing those things, when you're requiring immediate medical intervention, right? Nurses care for many patients during their shifts. Strong critical thinking skills are crucial when you're juggling various tasks, so so that patient safety and care are not compromised, right? So you're continually critically thinking and reprioritizing each of your patient's needs, right? So you're not able to just do a little checklist. That doesn't work. Nurses must also critically think to determine which patients to see first, which medications to pass first, and in the order in which to organize their day caring for their patients. So yes, you're going to organize your day, but please know that you're going to have to pre-organize your day and reprioritize as you go through and figure out that patient in room 112 is not as stable as the previous shift had. It had shown that the patient was trending. Now they're not trending that way, and now they have bumped up to a priority. So you're going to reprioritize and remake your list, right? Organize your day in your afternoon, right? Patients' conditions and environments are continually changing, and therefore the nurses must continually change, right? I mean, it's what they say in Texas, tit for tat. If your environment's changing, you got to be as flexible as your environment, right? Okay, so next is the nursing process. So the nursing process, you will hear Marcel and I refer to the nursing process as ADPI. So we have assessment, gathering data, diagnoses, planning, implementation, and evaluation. Okay, so we're going to delve deeper into this, right? Because we do know that an RN uses this systematic, dynamic way to collect and analyze data about a client. And this is the first step in delivering nursing care, right? So when we do ADPI, this is part of nursing care. So when we look at assessment, it includes not only the physiological data, right? Not only the physical needs, but also the psychological, the sociocultural, the spiritual, economical, lifestyle factors as well. We're looking at all of this, right? So for example, a nurse's assessment of a hospitalized patient, let's say that patient is in pain, includes not only the physical causes of pain and the manifestations of pain, right? But also the patient's response to that pain, their inability to get out of bed, their response of refusing to eat. They're withdrawing from their family members because they're in so much pain. They're angry at the hospital staff. They're scared. They don't know what's going on with them, so they're terrified, right? So they're withdrawing. Or they may request more pain medication, right? Okay, next one is diagnoses. So the nursing diagnoses is the nurse's clinical judgment about the client's response to an actual problem, right? An actual healthcare problem, or even a potential healthcare problem or condition, right? So your diagnoses, of course, will be based on the patient's signs and symptoms, right? Again, so for example, the diagnoses with that previous example doesn't reflects not only that the patient's in pain, but that the pain has caused other problems like anxiety, poor nutrition, conflict within the family, and other potential problems, right? For example, because of staying in bed, I can just think of another one right off the bat. Sitting in bed causes your body to collect fluid in your lungs, right? And that can lead to respiratory infections, right? 'Cause what better environment for bacteria to grow in the lung than in a dark, warm environment where fluid's not supposed to be, right? That's why you're supposed to be up and walking around so that you get those fluids moving through and that you don't, get any blood clots and a ton of other reasons. So the diagnosis is the basis for the nurse's planning or plan of care, right? So the next stage is planning. So literally, what is the patient-centered goal to be achieved? What does the patient's goals need to be, right? So based on the assessment and diagnoses piece, the nurse sets measurable and achievable short and long-term goals for this patient that might include, for that previous example, moving from bed to chair at least 3 times a day, or maybe maintaining adequate nutrition by eating smaller, more frequent meals, or maybe resolving conflict with their family through counseling, or maybe managing that patient's pain through adequate medication management. So that's important. And then the assessment data, diagnoses, and goals are written in the patient's care plan so that nurses, as well as other healthcare professionals caring for the patient, have access to it and can see exactly what the plan of care is, right? Okay, the next phase is implementation. So what steps will be taken to achieve this goal? So our nursing care is implemented according to the care plan. So continuity of care for the patient during their hospitalization is done this way and through this, and also preparation for discharge needs to ensure that those are met as well, right? So care is documented thoroughly in the patient's medical record. And then the last and final stage is evaluation. Literally looking back and seeing, did the implementation work? And if not, what happened? Why did we not reach those goals, right? And we got to start with the patients with that evaluation. We got to go back to the patient and see exactly what the problem was, right? So both the patient status and the effectiveness of the nursing care must be continuously evaluated and the care plan modified as needed. And it's continually modified as you go along, right? Until it's met, and then you move on to the next one. Okay, again, I can't stress how important this is, the nursing process, right? And it consists of assessment, diagnosis, planning, implementation, and evaluation. The acronym MADPI is an easy way to remember the components of the nursing process, right? And the order that they're typically achieved in. And nurses need to learn how to apply the process step by step. However, As critical thinking develops through experience, you will learn how to move back and forth among these steps of the nursing process, which will make your understanding of what's happening with your patients medically and nursing wise clearer to you, right? So again, trust the process, right? I know I keep harping on that, but really it does work. The steps of the nursing process are not separate entities, but they're overlapping, and it's continually a sub process that's going on in the background, right? Apart from understanding nursing diagnoses and their definition, the nurse promotes awareness of defining characteristics and behaviors of the diagnoses, related factors to that, those selected nursing diagnoses, and the interventions suited for treating those diagnoses, right? So again, ADPI, very, very important. Nursing process, very important. So again, looking at assessment, what is the assessment piece of the nursing process? Exactly what data is collected is basically what we're asking, right? The first phase of the nursing process is assessment. It involves collecting, organizing, validating, and documenting the client's health status at that time. This data can be obtained in a variety of ways. Usually, when the nurse first encounters a patient, the nurse is expected to assess to identify the patient's health problems as well as the physiological, psychological, sociological, emotional state, and to establish database about the client's response to their health concerns or their illness, and the ability for them to manage their healthcare needs. Of course, this comes at after, we're not talking the very first time. So the first time you pop your head in after you get reported is to make sure they're alive and breathing and have no current severe needs, right? Then when you go back in, that's what I'm talking about. This is when you're going to do this. Okay, collecting data. So data collection is the process of gathering information regarding the patient's health status. The process must be systematic and continuous in collecting data to prevent the omission of important information concerning the client. I mean, even missing one key thing could really alter the care so drastically in some cases that it could be life-threatening. So it's very, very important that we're continually staying on top of this throughout our shift. The best way to collect data is through head-to-toe assessments, right? And I can't stress how critically important your assessments are. Now, as a student, you need to listen to as many heart and lungs and all the bowel sounds you can get your hands on. Every student, every family member, whatever you can do to listen, right? Because the only way you're going to train your brain to recognize the difference between coarse crackles and fine crackles, or rhonchi, or any of the other things, right, is for you to continually practice that. So that's critically important, right? All right. Types of data. Data collection about a patient generally falls into either objective categories or subjective categories, but data can also be verbal and nonverbal. So for the most part, it'll be objective and subjective, but also nonverbal and verbal. So let's start with objective and data and signs. So objective data, we call that overt. It's very measurable, very tangible data, right? And it's via the senses such as sight, touch, smell, hearing. And so compared to an acceptable standard such as vital signs like intake and output, height or body temp, pulse, respiratory rate, blood pressure, vomiting, distended abdomen, presence of edema, lung sounds, and all those things, right? So again, it is objective, very overt, measurable, tangible data. This is always the stuff, objective data is the nurse's assessment of your patient. So, all of that definitive, obtainable, touch, hearing, smell, sight, all of those things, right? Okay, sorry, I digress. Subjective data is what your patient says, right? So subjective data involves covert information. It deals with feelings and perceptions and thoughts and sensations and concerns, right? So things that can't be definitively quantified. It's not like a set of vitals that is a number and it's definitive, right? No, this is subjective data that is, a patient's feeling or perception or thought, or, so all of those things, right? Um, and can only really be verified by the patient, right? So the patient's saying, for example, let me give you some good examples. I'm nauseous, right? You can't see the nausea, right? And some students have trouble with this one, pain. But when a patient tells you about their pain, whether it's, uh, you know, it's dull or it's deep or it's constant, intermittent, right? They're describing their pain to you. So that is subjective. Now, can a nurse objectively quantify pain? Absolutely. How do we do that? With a pain scale, right? And we're going to talk more about that later in the block, right? Other things that are hard, that are subjective would be a patient saying that they're numb. You can't see it, right? That they're having pruritus or itching, right? You might see the welts, but you can't actually see their itching, right? Their attitudes, their beliefs, their values, their perception of their health concern, their life events, all of those things, right, that the patient's experiencing is subjective, right? Okay, next is verbal data. So verbal data is spoken or written data, such as statements made by the patients or by a secondary source. Verbal data requires that the listening skills of the nurse are outstanding so that they can assess the difficulties such as slurring, tone of voice, assertiveness. A good nurse will hear anxiety in a patient's voice, difficulty in finding the desired words. If they're having a flight of ideas, we can see so much just how the patient verbally communicates with us, right? And then we have nonverbal data. So we have nonverbal data is what we observe, the behavior that's transmitting a message to us without actual words, right? So like the patient's body language, their general appearance, facial expressions, gestures, right? When someone's mad if they give you the middle finger, right? Eye contact, right? What if they're not making eye contact, right? How close they stand to you. When someone gets in your personal space, right? If they're from, a culture that's recognized, right? Some cultures just don't recognize it and they don't get that personal space is a problem, right? Because it's not in their culture. But if they get it and they come into your space, you're like, whoa, that's sending a message, all right. Touch, posture, clothing, all that stuff, right? Nonverbal data obtained can sometimes be more important than verbal data. It genuinely can, especially if you have your patient saying one thing, but all of the other nonverbal is saying another. You really got to listen to that nonverbal. It can be very, very beneficial. Um, and as the client's body language, again, when it's not congruent, really take the whole thing into consideration, right? And helping guide your communication and your actions, your assessment and all that. So obtaining and analyzing nonverbal data can help reinforce other forms of data that we've collected, right? And really can help also understand what the patient, truly how they feel, right? Which is definitely a piece of it. Sources of data is our next category, and we can get sources of data through primary sources, secondary sources, or tertiary sources, right? So the client is the primary source of data, while family members, friends, support persons, work peers, records, other healthcare professionals, laboratory diagnostics, all of that stuff falls under secondary sources, okay? So again, primary source. The client is the only, let me repeat this, the client is the only primary source of data and the only one who can provide subjective data. Let me repeat that. The client is the only one who can provide subjective data and is the primary source of all data, right? Anything the client says or reports to the members of the healthcare team is considered primary source. Secondary source is considered from someone other than the client, but within the client's frame of reference, right? So anybody connected to the client, as all of those examples I listed above. Information provided by the client's family, significant other, work friends, family, extended colleagues, all of that stuff is considered secondary source of data if the client cannot speak for themselves. or if the client is lacking facts and understanding, or if the client's a child, right? So we do get secondary source in those cases. Additionally, the client's records and assessment data from other nurses or other team members of the healthcare team are considered secondary source of data as well. So like I listed above, all the lab reports and all of that. And then we have tertiary sources from outside the client's frame of reference are considered tertiary sources of data. So this would include textbooks, nursing journals, medical journals, drug handbooks, surveys, policies and procedures, all of that good data. Now, the main methods used to collect data are health interviews, physical examinations, and of course, observation, right? We do a ton of observing. Health interview, the most common approach to gathering important information is through an interview. An interview is intended communication or a conversation with your patient that has purpose. For example, to obtain or provide information. Maybe it's to identify problems that the patient's having, maybe evaluate a change that's occurring in their life and in their, chronic illness. Maybe to teach them something, right? Maybe they have a new drain, or maybe they have a new wound orders or something, right? Or it could be simply to provide support. And I don't mean to say simply like it's simple, because it's not, right? It's a big piece of what we do, but it is to provide support or provide counseling or even therapy, right? Getting the right people in at the right times. For example, one example of the interview is the nursing health history, which is a part of the nursing assessment, the admission assessment. So again, the nursing health history is part of the nursing admission assessment, right? And remember, an admission assessment has to be done by an RN, not an LPN, right? LPNs can reassess, but they cannot do any of the nursing process, the ADPI. But they're very good with a supportive role for going in and doing reassessing, re-education, all of that, right? But they're not the primary individual who's responsible for all of the nursing process or ADPI. Patient interaction is generally the heaviest during the assessment phase of the nursing process, right? It's when we spend the most time with them. And that's when we're building that rapport. And a rapport has to be established, or I should say must be established during the step if you're going to really generally provide quality, thorough care, right? That covers all of the needs and not just the physiological needs, right? Physical examinations. So aside from conducting interviews, nurses will perform physical examinations. I've already discussed how critically important they are, right? We will also look at referencing patients' health histories. We'll obtain patients' family histories. We may do a general observation and also gather assessment data. Establishing a good physical assessment would later on provide a more accurate diagnosis, right? More accurate planning, better interventions, and of course your evaluation and outcomes would be much better if your assessment data is better, right? All of it being much, much better and much better for patient outcomes. Observation is an assessment tool that depends on the use of the five senses. So again, we're looking at sight, touch, hearing, smell, and taste. We're doing this to learn information about the patient, right? This information relates to characteristics of the client's appearance, functional ability, primary relationships, and also the environment, right? Although nurses observe mainly through sight, most of the senses are engaged during careful observation, such as smelling foul odors, hearing or auscultating lung and heart sounds, and feeling the pulse rate and other palpable skin deformations. So you will find, we'll teach you tricks like when you want one of your other senses to be sharper, then you make sure you're not utilizing the rest, right? So for example, if I want my touch to be sharper, then I will look away when I'm palpating a pulse, right? Because now without the eyes, I can feel the pulse better. Believe me, it works. Give it a shot, right? We'll practice it in lab. Okay, so my computer keeps jumping to other information. Good grief. Okay, so Validating data. So, validation is the process of verifying the data to ensure that it is accurate and factual. One way to validate observations is through what we call double checking, and it allows the nurse to complete the following tasks, right? So, for example, ensure that the assessment information is double checked, verified, and complete, right? What's the first thing you do when you get a blood pressure that's outside the norm, whether it's high or whether it's low? You check it, right? You revalidate it. Right. So that's what we're doing. We're double checking. You don't just make assumptions that the patient's in a hypertensive crisis, right? So, so you get a blood pressure of 210 over 96, and they don't have a history of hypertension or any other facts like that, right? So to validate the data, the nurse should retake the blood pressure, and if necessary, use other equipment to do so. Maybe there's something wrong with that blood pressure cuff, right? Or you could even ask someone else to perform the task if it's something more in depth other than blood pressure, but you want to get validation that it's an actual assessment. And as new nurses, by the way, we do this within the first year, especially just to reassure us that we're seeing and hearing what we see, right? And feeling and so forth, right? Okay. Ensure that objective and related subjective data are valid and accurate. For example, the client's perceptions of feeling hot need to be compared with the measurement of the body's temperature, right? We know that there's times when patients feel hot, right? It could be hormonal, it could be other reasons, right? That may not indicate that it's an actual elevated temp in the body, not necessarily. Ensure that the nurse does not come to a conclusion without adequate data to support that conclusion, right? We never draw conclusions without supportive data, period. A nurse assumes tiny purple. So we might go, for example, if I go into a room and I'm looking at a patient and they have tiny purple or bluish black swollen areas under the tongue of an older adult client, we're going to assess that to be abnormal until reading about physical changes of aging, right? So if I didn't necessarily know that with with aging, physical changes with age, that sometimes you get tiny purple or bluish swollen areas under the tongue. That's a normal part of aging. If I didn't work with the elderly and I didn't know that, right? Or as a new nurse and I hadn't seen it yet, that's how you learn, right? Maybe I had forgotten that I learned it in nursing school or something, right? And then a peer would say, no, that's just a normal part of aging, right? And we'll talk about that further, about the whys behind that. Ensuring that any ambiguous or vague statements are clarified. So it's our job to make sure that if a patient states ambiguous information or vague information, we're clarifying that. And trust me, it happens all the time, and you just need to be persistent and ask the right questions. Again, we're going to practice this in class and lab to get to the bottom of that vagueness, right, that's occurring there. So for example, an 86-year-old female client who is not a native English speaker says, I'm in pain on and off for 4 weeks. So I'm in pain on and off for 4 weeks. That would require verification for clarity, right? From a nurse by saying, can you describe what your pain is like now? Would you rate that, from 0 to 10? And exactly what do you mean by on and off? Did you have it daily? Was it intermittent? Like, you need to get real specific on these conversations. And again, if it's English as a second language learner, then it's not fair not to have an interpreter in there to have those conversations with the patient, right? And remember, family members don't speak medicine and should not be used as interpreters. So make sure that you're not doing that unless you're in a situation where you don't have any other, choice. Like I don't know what that would look like. We all have access to interpreters, so just make sure you're using it. Okay. There may be times when you acquire additional details. There may be some details that have been overlooked. For example, a nurse asking a 32-year-old client if he is allergic to any prescription or non-prescription medications, and what would happen if he took those medications, right? So don't forget about those things that can get overlooked, especially when you're, busy doing all the other pieces of your assessment and your head to toe and all of that, right? Just don't forget the basics, I guess. You got to be good at distinguishing between cues and inferences. So, cues are subjective or objective data that can be directly observed by the nurse. That is, what the client says or what the nurse can see, hear, feel, smell, measure. You can see that, right? So, that's cues, right? On the other hand, inferences are the nurse's interpretations or conclusions that we make based on those cues, right? So, for example, the nurse observes the cues that an incision is red, hot, and swollen, right? So we're seeing an incision that is red, hot, and swollen, right? It shouldn't be red, hot, and swollen. It should be well approximated, meaning the stitches come together. It lays nicely flat and it's beautiful. No redness, no swelling, right? So the cues are the red, hot, and swelling, and the inference I'm going to make is that incision is infected, right? So that's the difference between those two. All right, documenting data. Once all of the information has been collected, data can be recorded and sorted, right? So excellent record keeping is fundamental so that all the data that is gathered is documented and explained in a way that it is accessible to the whole healthcare team and can be referenced during evaluation. Diagnoses. So, two, what is the problem? The second step of the nursing process is the diagnosis. The nurse will analyze all the gathered information and diagnose the client's conditions and needs, right? So, diagnosing involves analyzing data, identifying health problems, risks, strengths, and then formulating a diagnostic statement about the patient's potential or actual health problem. More than one diagnosis is sometimes made for a single patient, right? So formulating a nursing diagnosis by employing clinical judgment assists in the planning and implementation of patient care. The types, components, processes, examples, and writing nursing diagnoses are all discussed more in detail in the guide that is attached in the notes here. So if you'd like to see it, you're more than welcome. We also will have much, much more on this, right? A nursing diagnosis is initiated by a nurse and describes a response to the medical diagnoses, okay? Now, one of the things you're going to have to be able to do that I want to warn you is a little challenging for students is being able to decipher between a nursing diagnosis and a medical diagnosis. We are going to test you on that, right? And so you have to be able to decipher between the two. We as nurses do not focus on the medical diagnoses. That's the doctor's job. Our job is to focus on the nurse's diagnosing, right? And again, students tend to have a difficult time with this in the beginning, but guess what? With time and practice, they are pros by the mid block. So just trust the process and know that it's going to take some time and practice to discern between these two, right? And we'll be doing this immediately. I think it's in week 1, if not, definitely in week 2. We're going to practice this a lot. And you will need to be able to do this with every single patient multiple times, right? It will become innate to who you are really as a nurse, right? So plan for this process to take some time, but again, give yourself some grace. It's a learning process. Thinking like a nurse is nothing like one has ever done, right? And so give yourself some grace. Medical diagnoses, on the other hand, deals with the disease or medical condition, right? But the nursing diagnoses deals with the human response to that medical disease or that actual or potential medical problem, right? So there's the difference. We're worried about how it affects the patient and what we can do to improve those or outcomes or to minimize, the negatives to that exacerbation of their chronic illness per se. So again, for example, let me give you a specific example. I love giving specific examples. Students tend to remember these on exams and they help. So medical diagnoses of a stroke, right? A cerebrovascular attack provides information about the patient's pathology, right? The complementary nursing diagnoses for somebody who has a CVA or stroke would be impaired verbal communication, or it might be risk for falls, right? Because they're weak on one side, or it might be interrupted family processes because the patient is struggling with the fact that they're no longer the caregiver for the family and now they're struggling with that, right? So maybe even powerlessness, that would be perfect for that example, right? It provides a more holistic understanding of the impacts of that stroke on this particular patient and his or her family. And then that also directs our nursing interventions to come up with more patient or person specific outcomes, right? So looking at the patient, not just medically, but also from all of the holistic aspects that we talked about earlier. Planning. So how do we manage the problem? So planning is the third step of the nursing process. It provides directions for nursing interventions. So, excuse me. So when the nurse or any supervising medical staff and the patient agree on the diagnoses, the nurse will plan a course of treatment that takes into account short and long-term goals. Each problem is committed to a clear, measurable goal for the expected benefit outcome, right? So we come up with very clear goals with purposeful outcomes. The planning phase is where goals and outcomes are formulated that directly impact patient care based on the best evidence-based practice guidelines that we're currently practicing with, right? These patient-specific goals and the attainment of such will assist in ensuring that the patient has a positive outcome, right? Nursing care plans are essential in this phase of goal setting. Therefore, we're going to be doing a care plan every week of clinicals. Well, 5 of the 6 weeks we'll be doing care plans, right? They're critically important, and you do need to spend the time and energy into learning how to do them appropriately, because that's going to cement the concepts and the whole process, what we do in our careers and with every patient, into your permanent memory, right? Care plans provide a course of direction for personalized care tailored to that individual and unique needs, right? Overall condition and comorbid conditions play a role in the construction of your care plans, right? So care plans enhance communication, documentation, reimbursement, continuity of care. It just helps ensure that the patient's care is 100% at all times. Planning starts with the first client contact and resumes until the nurse-client relationship ends, right? So upon admission and until discharge, preferably when the client is discharged from the hospital, right? Initial planning is done by the nurse who conducts the admission assessment. Again, that needs to be an RN. Usually the same nurse would be the one to create the initial comprehensive plan of care, again, an RN. Ongoing planning is done by all the nurses who work with the client. As a nurse obtains new information and evaluates the client's responses to care, they can individualize the initial plan of care further. And an ongoing care plan also occurs at the beginning of the shift, again by an RN. Ongoing planning allows the nurse to determine the client's healthcare status, whether that has changed or it has improved, setting priorities for the client for our shift, deciding which problem to focus on during the shift, right? And there is a algorithm for determining which patient is most critical, right? So we start with airway, then next is breathing, next is circulation, and then we have Maslow's hierarchy of needs, right? And we're gonna do care based on those things, right? Coordinating with nurses to ensure that more than one problem can be addressed at each client contact. And of course, discharge planning is the process of anticipating and planning for needs after discharge. To provide continuity of care, nurses need to accomplish the following, right? So you're going to start discharge planning for your patients on day 1 of admission. So as soon as they walk through that emergency room and they're admitted to the hospital through the ED, that is the day we start planning to discharge them, right? And this helps guide our care, get them to the healthiest place possible. So honestly, discharge planning should be on day one because it's all about getting the patient to their optimal functioning level, preferably at their last most best ability per se. Anyway, I digress. We want to involve the patient and the patient's family or their support persons in the planning process, right? If the patient's on board, of course. Collaborate, obviously, with other healthcare professionals as needed to ensure that the psychosocial, cultural, spiritual needs are met. So we're going to reach out to social workers, chaplains, right? All kinds of people to help come up with this discharge plan and coming up with their plan of care, right? So developing their nursing plan of care. It's a formal process that correctly identifies the patient's current existing needs and recognizes potential needs or risks. Care plans provide communication among nurses, their patients, and other healthcare providers to achieve the healthcare outcomes that the patient wants, why they're there, right? Without the nursing care plan, without that process, the quality and consistency of patient care would be lost. It genuinely would, right? Because we would all be practicing with our own thoughts and beliefs, right? It wouldn't be organized in a fashion and it really wouldn't be based on best evidence-based practice, right? So it just makes sense to do that, right? And again, attached in your notes is the planning step of the nursing process, if you'd like to see the document. Okay, implementation phase of the nursing process is when the nurse puts the treatment plan into effect, right? It involves the action or doing and the actual carrying out of your nursing interventions outlined in the plan of care. This typically begins with the medical staff conducting any needed medical interventions. Interventions should be specific to each patient and focused on achievable outcomes, right? It's not helpful to have non-achievable outcomes because you're never going to get there. Actions associated with a nursing care plan include monitoring the patient for signs of change or improvement, directly caring for the patient, or conducting important medical tasks such as medication administration, educating your patient, guiding your patient on further health management, maybe referring or contacting the patient for follow-up, right? A taxonomy of nursing interventions, referred to as the Nursing Interventions Classification, or the NIC taxonomy, was developed by the Iowa Intervention Project, right? And the nurse can look up a client's nursing diagnoses to see which nursing interventions are recommended, right? So thank God they did the work for us, right? So we will be passing this out, nursing interventions taxonomy. So it literally looks up, based on this nursing diagnoses, what interventions are recommended. I shouldn't say we're passing it out, but you'll have access to resources that have this information in it, right? And then we have the NIC system, or the Nursing Intervention Classification System. It's more than 550 nursing intervention labels that nurses can use to provide the proper care to their patients, right? These interventions are categorized into 7 fields or classes of interventions according to the Nursing Interventions Classification System. And there are some really good NIC books out there that have great care plans in them for each type of illness that a nurse would come across if you want. And I wouldn't invest in a new book. What I would do rather is go, purchase books from, book companies that are going to give you a deal on it, right? And not charge you an arm and a leg. And we do have those companies. So ask us in class. We'll give you the names. I just can't think of them right now. I was trying to stall so I could come up with it, but I couldn't. So sorry about that. Ask me in class. Remind me, I'll tell you. And then we have the behavioral nursing interventions, right? So these interventions are designed to help patients change their behavior, right? So with behavior interventions, in contrast, patients' behavior is the key and the goal is to modify it, right? So for example, the following measures are examples would be like, maybe encouraging stress and relaxation techniques, or maybe even providing support to quit smoking, or engaging your patient in some form of physical activity like walking, or reducing a patient's anger or anxiety or hostility, right? There's a lot, right? But it's to modify that behavior, right? Next is community nursing interventions. So these interventions refer to the community-wide approach to healthy behavior change, right? So instead of focusing on mainly on the individual as a change agent, community intervention focuses and recognizes that a host of other factors that contribute to an individual's capacity to achieve optimal health is reliant on the community as a whole. So, for example, implementing educational programs for first time mothers might be an example, or maybe even providing diet and physical activities, or maybe even initiating HIV awareness and violence prevention programs, or maybe organizing a fund, raise money for breast cancer research, or something along those lines, right? Okay, next is the family nursing interventions. These are interventions that influence a patient's entire family, right? So when implementing a family-centered approach, it helps to reduce the threat of illness spreading when one family member is diagnosed with a communicable disease, right? Something that's contagious. So um, maybe maybe it would be educating family members about how to care for a patient, right? Or providing, um, you know, and then we have our health system nursing interventions. These are interventions that are designed to maintain a safe medical staff for all patients and staff. So obviously following procedures to reduce risk of infection, right? So disposing of needles, for example, so we don't poke our patients, right? Ensuring that patients' environments are safe and comfortable. So Q2-hour position changes on your patient to avoid pressure ulcers, those kinds of things. We have psychological nursing interventions. These are interventions related to the patient's physical health to make sure that any physical needs are being met and that the patient is healthy condition. So when we say physiological, we mean their physical needs, right? Nursing interventions might be, basic physical health, hands-on procedures like feeding to hygiene assistance, all of those things, right? It could be complex also. So complex physiological needs might be like insertion of an IV line to administer fluids to a dehydrated patient, right? So it can vary from really complex things to, simple things to more complex things. Safety nursing interventions are there to maintain a patient's safety and prevent injury. So, for example, educating a patient about how to call for assistance using the call light and not trying to get out of bed and fall, or providing proper instructions on how to use walkers, canes, bedside commode, shower, chairs, all those things safely. That's why we test you on that information, right? So, then the next is skills that we use in implementing our nursing care. So when we implement our nursing care, nurses use cognitive, interpersonal, and technical skills to perform our care plan successfully. When looking at cognitive skills, we're talking about they're also known as intellectual skills, right? So learning and understanding the fundamental knowledge needed that includes basic sciences, right? So all your anatomy, physiology, biology, microbiology, all that stuff that got you into the nursing program. Then on top of that is the nursing procedures, all of the underlying rationales with, all of the disease processes and all the different patients. Before we care for the elderly, we understand, the risks and what happens as we age and all of that, right? When we look at cognitive skills, this is also problem solving, decision making, critical thinking, clinical reasoning. So all of that upper mentation, cognitive, critical, components that is the creative aspects of the brain, right? Higher up there, higher learning, higher knowledge thinking. Then we look at interpersonal skills. These skills involve believing, behaving, and relating to others, right? The effectiveness of a nursing action usually leans mainly on the nurse's ability to communicate with the patient effectively, as well as communicate effectively with the other healthcare team members. So your interpersonal skills and communication skills are critical to the success of your patient, right? Technical skills are purposeful, hands-on skills such as changing a sterile dressing, administering an injection, manipulating equipment, bandaging, moving, lifting, repositioning clients. All of these activities require safe and competent performance, right? That's technical. The process of implementing typically includes the following. So, first step in implementation requires reassessing your client. So, prior to implementing an intervention, the nurse must reassess the client to make sure that the intervention is still needed, right? Because it took you some time to come up with that intervention. So, let's just make sure that it is still going to be needed and it's still effective, right? So by reassessing, we can see if that problem still exists. And if so, then yes, our intervention is still proper. Even if an order is written on the care plan, if the client's condition has changed, that is our job to notify the physician that that order is no longer valid and update them and get a new order, right? That's our job. So second step in implementation is determining the nurse's need for assistant. So other nursing tasks or activities may also be performed by non-RN members of the healthcare team, right? So members of the healthcare team, like our wonderful LNAs, right? The licensed nurse assistants or even unlicensed assisted personnel or caregivers, right? As well as other licensed healthcare workers such as LPNs and LVNs and other professionals, right? We need their assistance when implementing some nursing interventions, right? For example, such as ambulating an unsteady obese patient. Of course, they'll help us with that, right? Or even repositioning a client, or when a nurse is in an unfamiliar model, or maybe they haven't dealt with that traction in a long time, that traction equipment, right? And you need assistance. Okay, well, that's fine, right? That's what the healthcare team is there for. So remember that. Third step of the implementation stage is implementing the nursing interventions. So nurses must not only have a substantial knowledge base of the sciences, of nursing theory, of nursing practice, of the legal parameters of nursing interventions, but we must also have the psychomotor skills to implement our procedure safely, right? It is necessary for nurses to describe, explain, and clarify to the patient what interventions are going to be done, what sensations they will need to anticipate, and what the client is expected to do, and what the expected outcome is. It is our job to do that. So please remember this when you're going in to do your Foley checkoff or when you're practicing to place a Foley. Explain exactly what was ordered and why. And then when you go to insert the Foley, you want to tell the patient, okay, I'm going to insert the Foley now. You shouldn't feel pain, but you will feel some pressure. Try to take a deep breath and relax. It will make it easier, right? All of these things, it's our job to do that. So when implementing care, nurses perform activities that may be independent, they may be dependent, and they may be interdependent, right? So independent means I don't need an order. I don't need I can do all of these nursing things without having to have an order to do that, right? Dependent means if I'm giving this pain medication, I can't just, I know my patient needs pain meds, but I can't just walk over to the Pyxis and get out morphine, right? I got to get in touch with the doctor and get an order for that. That's a dependent nursing action, right? All right. Then we have, and we're going to talk more about independent, dependent, and interdependent, right? Working together as an interdependent collaboration on improving patient outcomes. Nursing intervention categories are grouped in. We group them into three categories according to the role of the healthcare professional involved in that patient's care. So, first of all, we have the registered nurse, right? And this individual is ultimately responsible for all, the direction of the patient's care, right? So they can perform independent interventions on their own without the help or assistance from any other medical person, such as routine nurse tasks, such as checking vital signs, educating a patient on the importance of their medication and how they administer it as the doctor's order, right? And then we have dependent nursing interventions where a nurse again cannot initiate dependent interventions alone. We either need guidance or supervision from a physician or another medical profession. So it might be prescribing new meds like we mentioned, or it could be inserting and removing a urinary catheter. Maybe it's providing diet. Maybe it's implementing wound or bladder irrigations, right? We need to have conversations about what with providers or other healthcare professionals so we know exactly how they want that done, right? And then interdependent nursing interventions, again, excuse me, a nurse performs as part of a collaborative or interdependent interventions other team members cross disciplines. So, like for example, post surgery, the patient's recovery plan may include medications from a physician, feeding assistance from a nurse, treatment by a physical therapist. You're going to have occupational therapy coming up as well, right? So you have all these interdependent collaboration, right? The physician may prescribe a specific diet to a patient, right? The nurse includes diet counseling in the patient's care plan. To aid the patient even more, the nurse enlists the help of the dietitian that is available in the facility. And we should always, always do this for our patients, especially if it's a special diet, right? Um, Let's see. It is the RN's job to supervise whatever care we delegate to our LPNs, CNAs, and other people that report through up to us, right? So delegating specific nursing intervention to other members of the nursing team is appropriate, right? As long as we are supervising that delegation, right? So consider the capabilities and limitations of the members of the nursing team and supervise the performance of the nursing interventions. Again, deciding whether delegation is indicated is another activity that arises during the nursing process, right? And the American Nurses Association, as well as the National Council of State Boards of Nursing, define delegation as the process for a nurse to direct another person to perform nursing tasks and activities. It generally concerns the appointment of the performance of activities or tasks associated with a patient to UAPs, LNAs, LPNs, LVNs, those kinds of things, right? But we retain accountability for the outcome. So if we need to go back in behind them and reevaluate, we have to do that, and we will many, many times, right? So nevertheless, registered nurses cannot delegate responsibilities related to making nursing judgments. So again, remember, every piece of ADPI assessment, right, diagnoses, planning, interventions, and evaluation, that has to be an RN, has to. Um, Examples of nursing activities that cannot be delegated to a UAP or LNA include, assessment of the impact of interventions of care. So we're going to put these, you know, SCDs, sequential compression devices, on your legs to prevent DVTs, right? So you can have a CNA put those on, right? But they cannot evaluate whether or not it was effective, right? Now they may do that because they're, critically thinking, but it's not their job. And if they tell us that they see something suspect, which of course they do and should, then it's our job to go in there and do the actual evaluation, right? Okay, lastly, documenting nursing activities. So we're going to record what has been done as well as the patient's responses. Always record the patient's responses to anything we do, the nursing interventions. We want to do that as precisely and concisely as we can. So many times I will literally quote what my patient says. Okay, evaluating. Did the plan work, right? So evaluation is the fifth step of the nursing process. It is the final stage of the nursing process, and it's very vital to a positive patient outcome. So once all nursing intervention actions have taken place, the team now learns what works and what doesn't work by evaluating what was done beforehand, right? And whether a healthcare provider intervenes or implements care, they must reassess or reevaluate to ensure that the desired outcome has been met. That is the thing, right? You're going to go back, excuse me, and reevaluate whether that has been accomplished. The possible patient outcomes are generally explained under three terms. The patient's condition has improved, the patient's condition has stabilized, or the patient condition has gotten worse, right? So those are usually the three outcomes. Steps in evaluation. So nursing evaluation includes step one. You're going to collect data. You're going to go back and collect data from the patient to see exactly, to try to figure out exactly why that goal wasn't met, right? You're going to compare the collected data with the desired outcomes, and you're going to analyze that, as well as analyzing the client's response to the nursing activities, right? Because maybe it wasn't met because the patient wasn't generally on board, but they didn't verbalize that when you were creating that plan of care. It could be a multitude of things, right? But that this investigation and evaluation will determine exactly what the cause was of the lack of achieving that intervention, right? And then we can come up with a whole new plan of care. Um, so go back, figure out, was it a success or failure? If it was a failure, you want to learn why, and then we want to modify, or we want to terminate the current plan of care and then create and modify a new one, right? So again, collecting data. The nurse collects data so that the conclusions can be drawn about whether goals have been fulfilled. It is usually vital to collect both objective and subjective data. So not only what your patient says, but also the concrete, verifiable diagnostic data. It has to be, again, documented concisely and accurately to facilitate the next part of the evaluation process. Next is going to be comparing the data with the desired outcomes. So looking at the documented goals and objectives of the nursing plan care becomes the standards or criteria by which we measure the client's progress. So again, whether the desired outcome was met, partially met, or not met at all, right? So they could have met it completely, partially, or we just missed the mark and it was not met. Or maybe again, it was due to, they weren't on board with the plan. The goal was met when the client's response is the same as the desired outcome. The goal was partially met when either a short-term outcome was achieved, but the long-term goal was not, or the desired goal was incompletely attained. So the goal was not, and then the goal was not met, it just wasn't met, right? Next is analyzing client's response to relating to nursing activities. It's also very important to determine whether the nursing activities had any relation to the outcomes, whether it was successful, accomplished or not, right? So we need to really analyze, was the goal met due to what we did, right? That's always a factor. And then, of course, next step is identifying those factors that either contribute to the success of the patient or the failure, right? So it's required to collect more data to confirm if the plan was, in fact, success or a failure, right? And again, different factors may contribute to the achievement or failure of those goals. For example, the client's family may or may not be supportive, or the client may be cooperative or uncooperative to support the activities, right? So either one, once they leave the hospital, if neither the patient or the family are on board, that's going to be problematic, right? And that may result in a bounce back to the hospital when the patient declines further. Continuing, modifying, or terminating the nursing plan care is next. So again, the nursing process is dynamic and cyclical. So we look at if the goals were not met, the nursing process begins again from the very first step, and reassessment and modification maybe continually need to be going on to keep the patient current and relevant depending upon your patient's overall general condition, right? So the plan of care may be adjusted based on new assessment data. And this is continually going on all the time, right? So problems may arise or change accordingly. And as clients complete their goals, new goals will be set, right? We always have to have multiple goals in place. If the client's goals remain unmet, then we as the RNs must evaluate the reasons these goals are not met or achieved, and then revise the nursing plan of care so that it is achievable, right? It's not helpful if it's not achievable. Finally, discharge planning is the process of transitioning a patient from one level of care to the next, right? So they're in the hospital at this level of care, which is 24 hours a day, right? And now we're transitioning home. So we're bumping your level up where you're now more independent going home. Or even you could be going to a SNF. Let's say you broke your hip and you're, older and you need a little bit of rehab. Still bumping up your level of care from an acute setting now to a skilled nursing facility, right? So that's discharge. So the main purpose of discharge plan is to improve the client's quality of life by ensuring the continuity of care once they leave the hospital and go to home or SNF or wherever it is they go, right? So that that continuity of care can be carried on in the home setting, in the skilled nursing facility, if a home health nurse comes in, or even if there's the families taking care of for the patient, right? Still helps with continuity of care with them. Excuse me. The American Nurses Association defines morality as your personal values, character, or conduct of individuals or groups within communities and societies, right? Ethics is the formal study of morality, right? And comes from a wide range of perspectives, right? So ethics really delves into a wide range of people's perspectives on what morality is, right? So, ethics and morals relate to what's right and wrong conduct in our society. While they are sometimes used interchangeably, they are different. So, you need to know that. Ethics refers to rules provided by an external source. For example, codes of conduct in your workplace, maybe principles in your religion, right? So here are the Ten Commandments per se. Morals refer to an individual's own principles regarding right and wrong. It's very important to understand that as a nurse, you may care for patients whose moral beliefs differ vastly than yours, and that's okay. Remember, we are always treating our patients as individuals and what they want, their goals of care, not our goals of care. And this can be hard to remember as a nurse when caring for our patients, but it is key to being the best nurse possible. Always put your patient's goals first. Examples of morals can include things such as not lying, being generous, being patient, being loyal, all of those things, right? I'm sorry, I have a tickle. I need a drink. Um, Example of ethics may include the ideas of honesty, integrity, respect, loyalty. And notice that both are guiding principles for top quality nursing care, right? Consequentialism is a type of teleological theory that suggests that the moral value, the moral rightness or wrongness of an act is entirely a function of the consequences or the results of that act. And the theory of morality is the duty or moral obligation from what is good or desirable as the end is to be achieved. Deontological theories have been termed formalistic because their central principle lies in the conformity of an action to some rule or law, right? So they're just conforming to it because it's a law. The first great philosopher to define deontological principle was Immanuel Kant, the 18th century German founder of critical philosophy. Kant's deontological philosophy stemmed from his belief that humans possess the ability to reason and understand universal moral laws, and they can apply that in all situations, right? Unlike many other ethical theorists, deontology does not focus on the consequences of individual behavior, right? It just simply looks at that, right? The ethical principles that nurses must adhere to are principles of justice, beneficence, non-malfeasance, accountability, fidelity, autonomy, and veracity. I would memorize these definitions, and more importantly, I would recognize them in a patient example, right? So the code's provisions require that a registered nurse advocate for their patients by providing safe care with compassion and a commitment to the patient's primary interest, right? Because it's all about the patient's goals, not ours. Ethical principles of nursing include looking beyond the bedside to individual self-regard and human rights while striving to maintain healthcare advancement and social reform and justice. Developing an ethical awareness can enhance and ensure quality care. Nursing ethical principles can broadly be categorized into four major ethical nursing principles. So, autonomy, right? This is an important one, right? The right to self determination. Autonomy in nursing means providing adequate information to allow all of your patients to make all of their own decisions based on their personal beliefs and values, even if they aren't the ones of the nurses, the doctors, or anybody else, right? Autonomy also relates to only providing nursing care within the scope of practice defined by the state that you reside in, as well as to your organizational rules, right? So, some examples of autonomy in nursing include administering PR medications or maybe assigning nursing duties based on level of competence, right? Beneficence is the promotion of good. So, beneficence in nursing relates to ensuring that the patient's best interest is considered, regardless of the nurse's personal opinion. So, some examples of beneficence in nursing might include providing comfort to a dying patient, or maybe assisting with tasks a patient cannot perform independently. Justice is fairness or an equal distribution of benefits across the board, right? So, justice in nursing relates to impartiality regarding a patient's age, ethnicity, economic status, religion, sexual orientation, all of that, right? And some examples of injustice in nursing may include impartiality when assigning clinical or prioritizing patient care, right? So you're not looking at when prioritizing patient care, you're not looking at the individual and their beliefs and stuff like that, right? You're literally assigning them impartially, meaning that everybody is given the same latitude and same, grace, right? And then non-malfeasance is the avoidance or a minimization of harm, right? So non-malfeasance in nursing requires that there is safety, the provisions of safe, effective, high quality care. Some examples of non malfeasance in nursing might include holding a medication due to adverse reactions, or maybe taking steps to ensure a safe work environment, right? And again, you do need to know these for your exam, your HESI exam, when you're taking your NCLEX for the remainder of your career, right? So make sure you know them. Dilemmas are clear conflicts that exist between two or more principles. Problems are competing moral claims or principles when one is clearly dominant over the other. Uncertainty is when one cannot define what the moral situation is or what moral principles apply. And distress is one where one is aware of the correct course of action, but their institution will have barriers from allowing that to, from allowing us to do that course of action. So it does cause a lot of stress among us, right? And then we have, the ICN, ANA, and then of course the Center for Ethics for Human Rights all have ethical standards that we strive to all the time. When we're looking at ethical issues, we're going to talk about confidentiality, right? So we have HIPAA. We're going to delve into HIPAA in the future. We're going to go in depth on use of restraints. Man, that's a tricky one. You got to be real careful with that one. We're going to talk in depth about that later on in the block. Truth telling, right? Got to always tell the truth, no matter how hard it is sometimes, right? Again, refusing to provide care. Going to talk about that. And then, of course, end of life decisions and palliative care, right, there's some moral and ethical situations. We're definitely going to discuss that in the future as well. The Patient Self-Determination Act of 1991 provides that the patient's advance directives, which are legal documents that provide instructions for us medical care, the medical staff, so that we know exactly what they would like to be done when they're not able to communicate their own wishes, right? So an advance directive now, since 1991, is can be filled out and then has to be abided by, right? So the two most common advance directives for healthcare is living will and the durable power of attorney for healthcare needs, right? So the living will is a written statement detailing a person's desires regarding their medical treatment in circumstances in which they are no longer able to express informed consent, like, and especially like an advance directive, right? Identification of a healthcare representative. So they're going to pick someone that they choose to act on their behalf, like a family member or another trusted person, right? And then that authorized personnel will have the legal authority to act on their behalf, right? We do have what's called a POLST, or a physician orders for life-sustaining treatment, is a written medical order from a physician, nurse practitioner, or a physician's assistant that helps give people with serious illness more control over their own care by specifying the precise exact types of medical treatments that they want to receive during a serious illness when they're maybe not able to say so, right? And final slide, ethical decision making refers to the process of evaluating and choosing among alternatives in a manner consistent with ethical principles. So in making ethical decisions, it is necessary to perceive and eliminate unethical options and to select the best ethical alternative. Nurses are tasked with providing quality care, which exposes them to ethical dilemmas that require a high sense of morality and when making, high sense of morality when making these decisions. So nonetheless, nurses are expected to showcase actions and decision making that are highly based on moral principles. So ethical decision making in nursing refers to the framework that that nurses use in making informed decisions while evaluating the impact of their actions, right? Such a framework helps us nurses arrive at the most satisfactory decision for all parties involved when facing an ethical dilemma. All right, you guys, this is the end of the Hinkle chapter on professional nursing.